All right, great. So thank you very much for your patience with me as well. My name is Breanna Weigel, and I'm a fourth-year PhD student at the National Centre for Neuroimmunology and Emerging Diseases, or the NCNED, at Griffith University on the Gold Coast. So thank you very much for the opportunity to present today and to share some work from my PhD project. So today I'll be talking about how the lived illness experiences of people with ME and people with long COVID can be incorporated into and inform Australian health policies to achieve the best possible health outcomes for patients. So I'd like to firstly acknowledge the traditional custodians of the lands on which we're meeting today and the lands on which I'm presenting today, the people of the Yugambeh language region. I'd like to pay my respects to the elders, past and present, and extend this respect to all Aboriginal and Torres Strait Islander peoples. So I'd like to start off my presentation by firstly acknowledging the voices and the stories of people who live with ME or long COVID. Throughout my PhD, I've been incredibly fortunate to be able to learn directly from patients, and being able to hear patients' lived experiences has been invaluable for me as part of my research journey. I'd also like to take this opportunity to thank everyone who's been a part of NCNED research. Patients are at the centre of all the work that we do at NCNED, and your ongoing support is what makes our research possible. So Stanley has provided a pretty in-depth explanation of the diagnostic approach to ME, as well as the typical symptoms that we see in people with ME. So I'll just give a brief overview of the illness burden of ME and how this overlaps with long COVID. So ME and long COVID are chronic illnesses that affect multiple body systems. The symptoms are widespread, debilitating, and interfere with people's ability to engage in their typical daily social and working life activities. So we know from Stanley's presentation that there's a suite of symptoms that is experienced with ME, and this is also true for long COVID, but what's really important is that we see a similar presentation of key ME symptoms in people with long COVID. And the most important of these is post-exertional malaise, or PEM. And this is really similar to what Stanley was speaking about in terms of PEN-E, or post-exertional neuroimmune exhaustion. So in the literature, as well as in NCNED research, we see that between 70 to 100% of people with long COVID experience PEM. We know from Stanley that this is a necessary, as a hallmark symptom of ME and a necessary requirement to fulfill ME case criteria. We know as well that about half of people with long COVID have an illness presentation that is consistent with ME according to this case criteria. So this tells us that there is a significant overlap in the illness presentation of ME as well as long COVID. We know as well that these two illnesses are similar in terms of their nature of onset. So long COVID, we know, is a post-infectious outcome affecting about between 10 and 30% of COVID-19 survivors. And in terms of ME, not in all cases, but in a large proportion of people with ME, ME onset follows an episode of acute infectious illness. So given these overlaps in symptom presentation as well as illness onset, current research is investigating the potential overlap and potential relationship between ME and long COVID. And Etienne and Kieran will share some more details about their discoveries among people with ME and long COVID in their presentations. But there's one more overlap between ME and long COVID that's worth noting, and that's that people with ME and people with long COVID tend to have a shared illness experience. So it's for this reason that it's worth considering people with ME and people with long COVID, these two patient cohorts, together in terms of designing care services and approaches to support services and health policies. And that's what my presentation will be looking at today, how the experiences of people with ME may inform and give benefit for people with long COVID and vice versa. So that's what I'll be looking at today. So in terms of the shared illness experiences between people with ME and long COVID, we know that in addition to the debilitating symptom burden, people who live with these illnesses face profound limitations on their quality of life and functional capacity. And as Stanley mentioned, this can range from about 50% reduction in daily activities and, for example, a reduced capacity to work, to being bedbound and requiring assistance with self-care activities. So given the extensive impact of ME and long COVID on patients' lives, managing these illnesses requires multidisciplinary care and support that is person-centered, holistic, and is integrated across the healthcare, disability, and social support sectors. And this is particularly important for ME and long COVID because there doesn't yet exist a curative treatment for these illnesses. Unfortunately, despite this, many people with ME and people with long COVID in Australia face difficulty in accessing necessary care and support. So some of the barriers to accessing these services include stigma, unaccommodating processes of receiving care or applying to access care, as well as people with ME and people with long COVID being deemed ineligible to receive care and support. So these barriers are largely underpinned by poor representation and poor recognition of patients' lived illness experiences in Australia's health policy. So as a result, there's a disconnect between patients' experiences and patients' needs with healthcare planning and service design. So there's a mismatch between the care that's being provided and the care that's actually needed. So to ensure that patients' care needs are being met, there must be improved representation and recognition of patients in health policy. So to understand the barriers, the current barriers to this, as well as the means of dismantling these barriers, I collaborated with the Deeble Institute for Health Policy Research last year to develop this health policy issues brief, and I will be talking a little bit more about our primary findings. So our issues brief identified 3 priority areas for which improvement is necessary to ensure that patients' experiences and their needs are considered in health policy decisions. So the first priority area was identification, and this is mostly looking at the issues with public health monitoring or surveillance of ME and long COVID in Australia. The second priority area was recognition, and this looks at the barriers to attaining disability status or accessing disability supports for people with ME and people with long COVID in Australia. The last priority area that we identified was consumer engagement. There's 2 main subsections to this issue, and these are a lack of collection of patient-reported experience data, as well as issues and a lack of co-production of services and policies with ME and long COVID consumers. So looking first at our identification section, this is mostly looking at how the healthcare system sees patients. So in terms of how we document the burden of particular illnesses in Australia. So to identify the amount of cases or the burden of an illness on the Australian population, we collect public health data through nationally distributed health surveys, as well as through reporting systems. So nationally distributed health surveys are sent out by federal departments, and these include things like the Census, the National Health Survey, and Australia's the Australian Burden of Disease Study. In terms of reporting systems, we have linked data linkage systems, such as the Medicare benefit scheme and the pharmaceutical benefit scheme, but we also have national minimum data sets. So national minimum data sets are sets of information that is mandatory to be reported from healthcare services. So this includes things like hospitalization data and notifiable infectious diseases. So historically, these 2 approaches to public health monitoring are not well equipped for capturing chronic illness data in people, specifically people with chronic illnesses. And one of the main issues with this is that nationally distributed health surveys tend to capture specific illness groups. So these illness groups tend to be those within Australia's 10 national health priority areas, as well as sometimes those that are leading contributors to Australia's disease burden. So the contributors to Australia's disease burden are determined through the Australian Burden of Disease study, which is conducted by the Australian Institute for Health and Welfare. So this particular study captures over 200 health conditions, none of which are ME or long COVID. So there currently is no national monitoring system to determine the burden of ME and long COVID on Australians. In addition, the diagnoses that are made in primary care are not translated to public health monitoring at the federal level. This is largely due to the data that's collected in primary care. There's not much data linkage from primary care services. So the data that's collected in primary care tends to stay within primary care. There's also no national minimum data set that's specific for capturing chronic illnesses. And most of the national minimum data sets that we have tend to be for the acute care setting, or again, for illnesses that are within those priority areas. So it makes it difficult to understand the burden of these illnesses on the population, and it makes it difficult to quantify the demand for health services. So if the demand isn't clear, healthcare services cannot then be planned to meet that demand. So it is essential that to understand the burden of ME and long COVID on Australia, that there be improved monitoring and improved surveillance of these illnesses in Australia. So our recommendations for achieving this are to expand the collection, sharing and linkage of primary care data, as well as to establish a national minimum data set for chronic illness that will be able to capture chronic illnesses such as ME and long COVID. Looking now at our second priority area, which was recognition, this particular section looks at the need, for health policies to reflect the impact of ME and long COVID on patients' lives. So we know that the functional limitations that are experienced by people with ME and people with long COVID are consistent with definitions of disability. And these include definitions from the Australian Institute for Health and Welfare, the Disability Discrimination Act in Australia, as well as the United Nations Convention on the Rights of People with Disabilities, and the World Health Organization International Classification of Functioning Disability and Health. We know as well that patient stories, patient accounts, they highlight the disabling nature of ME and long COVID, and as does Australian research, including research from the NCNED. So recent research from our centre has identified that there is a significant impairment in quality of life and functional capacity measures among people with ME and people with long COVID when compared with people, otherwise healthy populations, people without ME or people without long COVID. Despite this, neither illnesses are considered disabilities in Australia. There's also an issue of recognition in terms of disability assessments. There are unique symptoms and unique manifestations with ME and long COVID, such as PEM, that aren't well measured in disability assessments. And this means that the true impact of these illnesses on patients' lives is not well documented and is not well considered in terms of disability access decisions. So having this disability status entitles people to access necessary services such as care subsidies, income support, and accommodations such as flexible working arrangements. So failing to recognise the disabling nature of ME and long COVID makes it extremely hard for Australians who live with these illnesses to access care. And this type of care is particularly important for people with ME and long COVID who already face reductions in their capacity to work, as well as substantial healthcare costs. So to ensure that these necessary services are accessible to people with ME and people with long COVID in Australia, the disabling nature of these illnesses must be recognised in Australia's health policy. So our recommendations are to include ME and long COVID as disabilities, as well as to co-produce disability assessments with consumers to ensure that the impact on people's lives is being adequately documented and assessed. So finally, our last section of our issues brief looked at consumer engagement. And again, there's two major subsections in this space. So the first is the lack of patient-reported experience data, and the second is a lack of clear pathways through which patients' lived experiences and patients' needs can be used to directly influence policy decisions. So we'll firstly look at patient-reported experience data. So this particular data refers to patients' experiences with their experience, patients' perspectives of their experience with a particular health service. This type of data is, we collect this type of data to monitor care, safety, and quality. And for this reason, it's actually mandatory to collect this data in Australia. How this data is typically collected in Australia is similar to public health monitoring data. So again, through national surveys, and patient-reported experience data is collected nationally through the Patient Experience Survey. But like the public health monitoring, these surveys tend to capture specific illness groups. So there's no ME or long COVID specific data set of patient-reported experiences. These questionnaires also tend to look at the acute care setting, so normally in hospitals. And for people with chronic illnesses like ME and long COVID, the majority of care takes place in primary care or in specialist care. And there's not many resources in terms of assessing patient-reported experience data for those spaces that are outside of acute care settings. So again, our means of collecting this type of data isn't well equipped for collecting data from people with chronic illnesses. So the last component of consumer engagement is limited co-production with consumers. So co-production refers to the engagement of consumers at every phase of health policy and service design, health policy and service development. So from design all the way to delivery and distribution. And co-production is really important because it ensures that care is targeted and that it's going to be well received from consumers because it's appropriate and it's accommodating. But unfortunately in Australia, there are few avenues through which patients' needs and patients' experiences can directly influence policy decisions. So for example, there's no consumer group or there's no consumer representative group that must achieve consensus before a policy decision is made. So as a result, most of patients' engagement with policy decisions comes from things like parliamentary inquiries. And when this happens, it tends to be after the fact, so after an adverse experience with healthcare services, rather than engaging consumers at the time that the policy decision is being made to optimize health outcomes in the first place. So to ensure that services are person-centered and they're designed to meet the needs of patients, the involvement of patients directly in policy decisions must be broadened. So our recommendations for this are to firstly expand the collection of patient-reported experience data among people with ME and long COVID specifically across Australia, as well as to establish a consumer-led advisory group that is specifically designed for government to consult with and collaborate with so that consumers' needs are represented at the time of making policy decisions and to proactively shape policy. So the underlying theme of these three priority areas is that there is a lack of direct pathways between patients' lived experiences and influencing policy decisions and the design of services. So some of the barriers that I've spoken about have been previously identified as being relevant for people with chronic illnesses in general. So things like chronic illness surveillance, primary care data sharing, and issues with service accessibility. So the recommendations of our issues brief have been informed by existing proposals in already established frameworks, such as the National Strategic Framework for Chronic Conditions. But importantly, our issues brief discusses for the first time ME and long COVID specific issues, as well as means of dismantling these barriers. So in terms of what NCNED research is doing in this public health space, by documenting the lived experiences of patients, of people with ME and people with long COVID, NCNED research serves to contribute to the further development of health policies that ensure person-centered care that meets patients' needs. So we are looking at patients' lived experience in terms of illness impacts, so investigating quality of life and functional capacity, looking at whether these change over time, and if they do change, how do these change over time, and comparing these measures with people who don't have ME or long COVID. We also look at the healthcare interactions of people with ME and people with long COVID in Australia, looking at the type and frequency of services that are accessed to highlight the role of particular services in managing these illnesses, as well as patient satisfaction and experiences. Importantly, our centre also continues to investigate the pathophysiology and potential therapeutic targets of ME and long COVID. And Etienne and Kieran will provide some further details about our world-leading research in these areas in their presentation. So thank you very much again for the opportunity to present today. I'd like to acknowledge the NCNED team, our sponsors, and again, all the participants who've been involved in our research. I'd also like to thank the Deeble Institute for Health Policy Research and Adjunct Associate Professor Rebecca Haddock for the opportunity to develop this issues brief, as well as HESTA for supporting this collaboration. So thank you very much.